Okay. So, sorry, just a little bit of that again. Lisa Cerceo graduated from Rutgers. She has a double major in biology and psychology, a double minor in French and music. She completed her medical degree at the University of Medicine and Dentistry of New Jersey. And she's also raising, I think, a whole passel, right? Six children and working full time as a internal medicine doc. So, yeah, she's pretty amazing. So we're very grateful that she's willing to give us an hour of her life.
Oh, thank you so much for the invitation. I'm going to share screen here. And the Climate Smart Healthcare, now it's myself and Kathleen Shapley Quinn, who leads the North Carolina chapter of the Medical Society Consortium, their state-based group. And Lisa Del Buono is spending her time more on policy. So you may be seeing more of Lisa. We were very sad. We had a trifecta before. But Lisa is wonderful, and her passion is really policy. So I hope that this is helpful to the group. I was just saying I'm sure that this is one of them that didn't go to bed. Sorry. Oh, go to bed. Um, I hope that this is helpful because you all have a ton of knowledge and are all policy experts, I'm sure. So what I will try to do is talk a little bit about what I've done at the state level and then some of the policy potential policy actions that could be taken at a federal level. And some of this was summarized in a paper that a colleague of mine and I published in Nature Climate Change. So I have no disclosures. Well, I'll do just very quickly a background on sustainability. And if you all know this, I can skip through this part really fast. So please, shout out if you know any of this stuff. And then we'll go to federal and state. These will be the goals and objectives. Just quickly in terms of land acknowledgements, out of reverence of people, history, and place. I do just want to acknowledge that I'm speaking from the ancestral land of the Lenni Lenape, who were the original inhabitants of this area, and acknowledge the unceded occupied territory that is now possessed over the generations. So sustainability and healthcare, for many of us who are currently practicing or retired, we know the waste that is generated. And so when we're talking to our local policymakers, meaning that the heads of our health systems, our CEOs, our C-suites, we will often try to frame this problem in terms of clinical health. And so I'm sure you've all seen this infographic several times. It's great in terms of framing the scope of the problem for people who have never thought about it before. I will say it leaves out some of the depth and breadth of conditions. It leaves out things like malignancy and some of the neurologic conditions. And we know with policymakers, some of the communications research points to the fact that when you talk about the neurodegenerative changes and neurodevelopmental changes, particularly that happen in children, that's very impactful for our politicians. More so even than if we talk about cancer risk or things like that. So some really interesting studies about what's the best way we can frame things. In terms of pollution, I'll often try to frame this when I'm speaking with policymakers that about 1 in 5 deaths globally result from fossil fuel pollution. And even though there's a range of numbers from like 8 million to 14 million, I think this is a really nice graphic that kind of that lays that out, and it's easy for politicians and people who maybe aren't as familiar with the medical literature to relate.
Lisa, sorry, is part of your screen cropped off? I'm sorry.
Oh, it might be. I was trying to move the videos out of the way. I might have messed it up. Um, is that better?
It's smaller now. It was like a fourth of the right side of the page, and yep, now it's gone. Okay.
It's gone. Oh, okay. Okay. Um, I'll also point to things like Rob knows really well, like American College of Physicians voices that are well respected within the health community, to show to our healthcare leaders and also to politicians why this should be an important issue that they care about, and also point to the vulnerability of the people who are going to be most impacted. For some people, and it really depends on the audience. I practice in an environmental justice community. Cooper and Cooper Medical School of Rowan University are in Camden, New Jersey, which is historically between like the one and top 5 poorest cities in the country. So we have a lot of overlapping environmental justice concerns. And so that's very resonant for the people in New Jersey who know this area very well. It depends kind of, finding those levers that are going to be most impactful for your audience. But certainly we know that all of these populations are going to be greatly at risk. And we just got off a call talking about heat risk. So certainly like those outdoor workers are going to be at risk. We'll usually, when we have these talks, frame the scope of the problem. So U.S. healthcare produces 8.5% of U.S. greenhouse gas emissions, much higher than the world average, which is around 4.4 to 4.6%, which is not a surprise because we know how wasteful our healthcare is in every single aspect, whether it's paying middlemen and middle person insurers, all of the insurance waste. The same thing happens with our plastic waste and our energy waste. So taken in total, if global healthcare were a sector, it would be the 5th largest emitter on the planet. So really just a huge impact. And what will resonate often with healthcare CEOs and administration is looking at it in terms of access and quality with greenhouse gas emissions. And we know that on average, U.S. healthcare produces about 1,700 kilograms of CO2 equivalents per capita. And so we're this big outlier on the graph in terms of GHGs. But we also know that you really don't get any more bang for your buck above 400 kilograms of carbon dioxide equivalents per capita. So you see a lot of Western Europe, a lot of the developed world will be having much less greenhouse gas emissions, but they're still doing better in terms of access and quality. So France, Japan, a lot of those other dots are European countries. So just important to consider how the U.S. sits in comparison. And I'm sure too many of you are familiar with this Eckelman and Sherman paper. It is very frequently cited, where they took essentially the amount of greenhouse gas emissions and then using medical actuary formulas turned it into a disability adjusted life years lost. And so when in doing so, that 8.5% of US greenhouse gas emissions ends up being over 400,000 disability adjusted life years. And then if you use the medical actuary formulas and turn it into deaths, it ends up being about 40 to almost 100,000 deaths annually, which puts it on par with the deaths that occur from medical errors. In the famous Institute of Medicine report to errors human that came out around 2000 or so, that said that essentially a plane of people going down, I think it was like every week, and basically like 100,000 people annually dying of medical errors. So it puts the pollution that we generate when we're caring for people on that same spectrum. And we know from the IOM report that it resulted in a complete frame shift. So it resulted in root cause analyses, in FMEAs, in DMAIC structures, and in whole departments being set up just to deal with quality of care. So this is a really important analogy to make, again, with people who maybe hold the power within our health systems, and also framing this in terms of the health of the people who are coming into our health systems, so that you're delivering healthcare to people who come in with poor health, and then that healthcare eventually degrades the local environment, and that degradation of local environment exacerbates poor health. And I always think about my COPD patients or my asthma patients who are, living upwind of an incinerator. So just an example, and a lot of the trash coming from that incinerator comes from the hospital. So again, the To Air is Human report here. So, and again, I'm sorry if this is basic for the audience. Did you want me to skip through this, or I can go to?
No, this is great. Thanks.
Okay. Okay. Well, in order to try to affect a change, we need to understand where the emissions are coming from. So scope 1 emissions are those emissions that are coming directly from your facility, or from your company vehicles. And scope 2 is going to be your purchased electricity. Now, you would think that a lot of, you have these like big shiny buildings and you would think that that accounts for a lot of our waste, but it actually doesn't. Scope 1 and scope 2 combined probably only amount to about 20% of our greenhouse gas emissions. So scope 3 is everything else. It's all the supply chain, it's the transportation, it's the food, it's our research and our investments.
Oh, great.
Um,
Okay. All right. Thank
there's
you.
business travel, that there's a lot of other components that go into scope 3. And this was also where, a bit of a bummer with the SEC regulations. When they were rolling out the SEC regulations originally, the plan was to have scope 3 included in that, so that there would be mandatory reporting, at least for-profit hospitals. Understanding that, the landscape is highly biased towards nonprofit hospitals. But if the for-profit hospitals had to disclose scope 3, it had the potential for kind of driving the market in a direction of more sustainability and transparency. Because they didn't include that scope 3 in the final SEC reports, we only have scope 1 and scope 2. Still better than nothing, but of course it's being challenged in court now. So we're not going to know if it's going to hold up and if it's going to go to SCOTUS, and we know what's going to happen if it hits there. So hopefully it will be able to have some wings just as it stands. And again, even if it is just in for-profit institutions. So there's a lot of different areas that you can potentially address greenhouse gas emissions, a lot of opportunities. And we did some of this at the state level in New Jersey. So I'll go into that towards the end of the talk. But another really, I think, helpful framing, that this is actually from Courtney Howard in Canada. She uses this analogy, and these slides here are on her website. She'll talk to C-suite people, she'll describe that the environment is basically the foundation allowing us to do our work. So if you don't have this foundation, and then you don't have the ecosystem to be able to do your surgeries. You're not going to have the supply chains to get your surgical instruments and your anesthesia, and you're not going to be able to have nurses and physicians coming in if there's natural disasters happening all around you. So portrayed like that, as the foundation that lets us do our job as physicians, that can sometimes be another messaging tool that can be impactful. Okay, so policy overview. So you all know all about the IRA. Relevant to health systems, the Office of Climate Change and Health Equity, which has only been created. It doesn't have a permanent status. It's been created by the White House, and really with a shoestring budget and a small staff. And so they've been doing a lot to try to help health systems access IRA funds, because there's a lot of opportunities where health systems could get the funding. But the problem is that they don't have the personnel to go through all the hoops to apply for these. And so they had set up the Catalytic series, where there's a series of lectures to try to help health systems through this. And they really are doing a fabulous job. It's just hard if you don't have someone in the C-suite who can run the numbers and apply. And there's also a lot of hoops. So in order to get funding X, you would have had to do X, Y, and Z first. So you have to do all of these things to be able to actually get the funds at the end of the day. And certainly, the IRA is wonderful and certainly gets us much closer to our goals than if not. And we can also tout the health benefits up to 4,000 premature deaths just within 6 years. So that these deaths are averted in a very proximate way, and that it's not far off. Again, these are all things that we can bring up, particularly if there's other policies like carbon fee and dividend or other policies, just to show the proximate nature that health can be impacted. And then there's the HHS pledge. So this was also out of the White House. It's a voluntary pledge, though. So it's a voluntary pledge that people, hospitals who sign on to this will cut their greenhouse gas emissions 50% by 2030 and achieve net zero by 2050. And so there are hundreds and hundreds of health or of hospitals that have signed up for this. I will say that a lot of them are not on track to meet their pledges because, again, it's voluntary, and there's nothing happens if they don't, and they get the good press of saying that they signed on to it. So no one's really holding their feet to the fire, which is unfortunate, and why we think, much as with CCL, we think that there needs to be legislation in order to make these kind of changes. So the interesting thing with HHS, and so I had to kind of I had to do homework on this, because as I started having conversations with policymakers, I didn't realize just how complicated the landscape was for health policy. So HHS has about 13 agencies within it, things that we care about, like NIH and AHRQ. If you're thinking about potential funding for health system science research, would be helpful to have an evidence base on how we're going to roll out some of these sustainability works. HRSA, which does a lot of workforce grants, and of course CMS. So there's some really big powerhouses under the umbrella of HHS, but they all have slightly different purviews. So if you're talking to CMS, you're not necessarily going to be hitting. You have to tailor your policy to exactly which branch, which was something that I had to kind of learn through trial and error. This is not meant for you to read all of this. There's a really, really nice article, though, on the Kaiser website, if anyone's interested. And it's because it's so Byzantine. So the structure of health policy in both Congress and that the Senate is really Byzantine. So just as an example, there's 6 committees that deal the most with health issues. You would think it would all be HHS, but it's not. So just as an example, in the House, Ways and Means, because it sets tax policy, will oversee Part A of Medicare because it's funded by taxes. I guess like it makes sense in some kind of weird way. And Senate Finance is also in charge of tax policy, but it also oversees Medicare and Medicaid and some of the ACA, whereas the Ways and Means will oversee more of the ACA. So again, like you can already see like that this is just a bizarre system. For some of the things that we're going to talk about next, I honestly didn't even realize that the Help Committee existed, and I didn't realize that the Help Committee oversaw the Centers for Medicare and Medicaid. So I feel like this was probably a government 101 course that I should have taken in undergrad, but I didn't. So learning this the hard way. But again, if you're interested, the Kaiser Family Foundation is really a nice resource. And again, just getting to the complexity of the Senate's 20 standing committees, there are 12 that have significant health jurisdiction, which is just like crazy. So like the Small Business Standing Committee will oversee health insurance issues for small business. It's just bizarre. So the difficulty then of crafting policy that will address all of these different pockets of where health lives in the government becomes difficult, becomes a challenge. And again, oh, sorry, this is supposed to be Congress. Congress has 13 committees with significant health jurisdiction. So we talked a little bit about the Office of Climate Change and Health Equity. This can potentially be dissolved. So one of the policy actions that would be helpful would be to standardize this office and to give it roots so that it can't be dissolved if another administration were to, I hope not, but or were to come into power. Aside from the health policy, there's the other layer of non-policy actors. So all hospitals, health systems have to be accredited. And the Joint Commission, along with two other nonprofit entities, will do the accreditation on behalf of CMS. And they actually hold a ton of power. The Joint Commission was actually founded by a group of surgeons because the surgeons were unhappy that they had good outcomes at one hospital and then poor outcomes at another hospital. So they wanted standardization of quality. And Jonathan Perlin, who is the head of the Joint Commission now, really is interested in sustainability. So I was fortunate to be part of their technical advisory panel about a year and a half ago or so, where the goal was to have mandatory reporting requirements, just as for a lot of other quality metrics, so that you would have to report your greenhouse gas emissions. You would have to do that baseline accounting. You would have to look at your transportation GHGs. You would have to look at your anesthetic gases, because we know things like desflurane are potent greenhouse gases. They're like 2,500 times more potent than carbon dioxide. So they were going to bake all that into the requirements. And then they did field testing. And unfortunately, the hospitals, it was mainly the small and medium-sized hospitals, gave a lot of pushback. And some of this, I mean, some of this comes down to ideology. A lot of it comes down to, again, not having the person power. So, the person who does their maybe their sustainability work or their facilities work is also the head of security, and maybe closes up at the end of the night. So there just wasn't the person power to drive the reporting requirements. The Joint Commission is still very interested in moving forward, but they, as a private entity, they do also need a little bit of help. And again, that's where policy comes in. Part of the reason that they need help is that there are these two other accrediting organizations, which are much smaller. The Joint Commission has like 80% of the market, and they're an international organization. Interestingly, DNV, and I didn't know this until I did some digging actually for this talk. I didn't realize that DNV from Norway also provides regulatory and accreditation services for oil and gas and renewable energy. So DNV and the other hospital accreditation program, which is HFAP, do not have any kind of sustainability requirements. So right now, from our MSCCH, the Medical Society Consortium's Climatesmart Healthcare Working Group, we're working on a CHA fellowship program where ideally we would be targeting these two smaller accrediting bodies to try to get them up to speed with the Joint Commission, because the Joint Commission doesn't want to float this and then have all of their business go to these two other entities. So we're trying to support that and raise the boat so that there's a level playing field. So again, one of the policy recommendations then would be to really have this permanent hub with appropriate staffing. And these were part of the policy recommendations from our paper that was published about a month ago or so. And to really memorialize OCCHE within the Federal Health Systems Learning Network and give them some jurisdiction so that they'll be able to say, for example, what happens in these other areas. Now certainly the decarbonization activities are much further ahead in the VA Indian Health Service because they are federal health systems. And then the emissions reporting. So right now there is, again, another voluntary initiative. So we'll probably have the same problem that we have with the HHS pledge, But right now within CMS, there's an innovation center, which was also news to me. So this innovation center will roll out different payment models. And so the team program, transforming episode accountability model, is essentially a different, an alternative payment model. And what they're going to do, they'll roll this out soon. I think the public comment period is just finishing up. They'll roll this out for a 5-year episode based model where essentially it aligns with what the Joint Commission is saying. So there'll be mandatory emissions reporting from transportation. Sorry, my cat's meowing. From transportation sector, from anesthetic gases. And the nice thing about the Decarbonization and Resilience Initiative is that in addition to the reporting, it has technical assistance. And we know that technical assistance piece is really valuable for hospitals where folks are tired, they're burnt out. So that's something that has the potential, if it was mandatory, to make a really big impact. As a voluntary initiative, I think we'll have to see how many people sign on. The other potential that would help was creating a national standard for the reporting platform. Epic, which has probably about 60% of the market share for electronic medical records, already has the ability to do some of these type of greenhouse gas reporting. They do it for anesthetic gases, so it could potentially collate some of that information and digest it. The team approach from CMS is going to be using the Energy Star Portfolio Manager, which is good, except Energy Star only covers Scope 1 and Scope 2. And we know that Scope 3 accounts for 80% of our GHGs. So that's a problem. But if you have a standard reporting platform, everyone knows what it looks like, everyone knows where the items have to go, then it does potentially make it a little bit easier and allows for benchmarking and performance tracking. So this would potentially be another policy solution if it's done in conjunction with other policies as well. Again, just a little bit more about team. So they've done some research on this. And if you go to the Decarbonization and Resilience Initiative, they've pulled the numbers in making the argument to the rest of the government of why this should exist. They've calculated that the federal climate-related healthcare spending could increase up to $22 billion just by the end of the century. And honestly, that's probably a big underestimate. All of these models, the models are incredibly complex, but not complex enough. And they also point out the fact that those that are going to be disproportionately affected are most likely going to be covered by federal government insurance, Medicare, Medicaid, CHIP. And so it would behoove the government to try to decrease those health expenditures. They had provided in their main document even some examples of the cost effectiveness, recognizing that hospitals are not necessarily going to do this unless there's a positive ROI that comes at the end of their financial accounting. So they gave examples with anesthetic gases when they changed the flow rates from energy savings. And there's this kind of information abounds. Practice Green Health, Healthcare Without Harm, has tons of case examples on their websites as well. And then technical assistance. So when out of the IRA funding, there is the EPA Community Change Grants. I don't know if you all have looked into these. I'm applying for a couple of them for the Camden community. They are a bear. Oh my goodness. But one of the nice things about that $2 billion that they carved out for the community change grants, $200 million is dedicated to technical assistance, because they recognize that these are going to be environmental justice groups that have most likely never applied for a grant as large as $20 million. And so they give you technical assistance up front. And so our thought is we should have the same exact thing for hospitals. This technical assistance should be baked in upfront to particularly help our safety net hospitals, our rural health centers, And I even found some examples within the USDA, where the USDA actually provided technical assistance to rural healthcare centers, not for sustainability, for other things, because they didn't want to compromise the agricultural workforce. And so again, like, you see like this complex patchwork of how health fits in. So the USDA is even trying to help healthcare centers. And then funding for research. We really should know at the best, the gold standard way to roll out some of these sustainability changes. And so I think AHRQ would probably be the best place for that to reside. Right now, NIH has funding for climate and health research, but it's at the patient level, which is of course much needed. But I think that this would be a nice adjunct to some of the policy discussions. And then some state-based solutions. So right now, some of the things that we're discussing is every state should have an Office of Climate Change. Only a handful do. That Office of Climate Change could be embedded within a Department of Health or a Department of Environmental Protection. It could interdigitate with interagency resiliency councils, or I'm sure they go by different names in different states, but these multiple agency councils that are working together to address, depending on the political climate, you might call it resiliency, you might call it sustainability or climate change. And then you could even get down to healthcare sustainability legislation. So that was what I did in New Jersey. I, through ACP, had pulled together a task force of the major representatives of the healthcare systems, and we drafted the site document. And if anyone's interested, that's the website. It's on ACP New Jersey. It's Sustainable Initiatives to Guide Healthcare Transformation. And we worked together, had probably about 4 or 5 meetings, and then drafted a 34-page document breaking down healthcare sustainability into these 13 subcategories, with a lot of subheadings under all of those. The thought was that we could then say that these are sustainability actions that the people in our state agree would be valuable to try to decrease cost and decrease our carbon footprint. And that it's not prescriptive. So you could do all, you could do one, you could do something in between. And we include things in that people have already heard of and are already familiar with, talking about like PDSA cycles, and integrating it into QI and really changing the equation for QI and value, because we always think of value as outcomes over costs, but the costs aren't just financial. So really expanding what costs mean into the environmental and the social impacts. And sometimes this will resonate with healthcare leaders. This is from Practice Green Health, talking about the return on investment is always very attractive. So I usually try to bring in these examples whenever I can. And talking to clinicians too, clinicians can change their practice from changing things like inhaler use. So instead of using meter dose inhalers with HFA propellants, you can switch to dry powder inhalers. And so there are these small changes, and we know that a lot of people don't use their inhalers properly anyway, especially, kids have a hard time with them. So possibly DPIs may be an option. Things like anesthetic gases, desflurane happens to also be very expensive. So when hospitals move away from desflurane, they often save money as well. Without any, some anesthesiologists have been concerned that people would be sleepy longer because I guess desflurane has a shorter half-life, but apparently that hasn't been borne out in the studies either. So this is a snapshot of one of the sections for resilience. So you can see we would have a goal example, and then we would have tons of different potential actions that a health system could take. And so, it could be from running disaster drills to developing an entire resiliency team. And when I'm talking about it to health systems, I'll often start with the resiliency aspect, because that can feel a little bit less scary. And they also, they see that something's in it for them, because they get to keep their doors open if there's a disaster, and they see the analogies too with things like COVID. So sometimes using that framework can be helpful. Where I am on the East Coast, I'll also bring up things like an evidence base showing that hospitals are not prepared. I mean, this particular study showed that about a third of the metropolitan areas are at risk for flooding, and they have not done their homework to try to protect themselves. About half or more of the hospitals are potentially at risk for flooding in those areas. And there's other toolkits that I'll sometimes pull into the conversation. But that's all I have right now. I'm happy to take any comments or questions about the work either at the state level or any of our potential policy actions.
Wow. I think maybe that should have been into a 3-hour one, but you wouldn't have had.
Oh, I should mention too, right now, I've had some very positive conversations with Senate Finance and with the Help Committee, which is Bernie's committee.
Yeah, so anyone with questions or comments, just chime in.
I can't believe you said that's all you have for us now. That was incredible. And I do think that breaking it down, since there was so much material here, would be very valuable in smaller chunks that help us to make use of what you presented. But I'm just blown away how incredible and rich that is. And I hope that we have access to your slides.
Oh, I can absolutely share them with you, of course. Would it be helpful to talk about the state level actions? I mean, I know most of what you do is federal policy. So I'm not sure which of those I should focus on.
Yeah, but I mean, like I mentioned to you, Lisa, I mean, the people on this call and the people on the health team tend to do a lot of other things besides
Right.
CCL, CCL policy.
Right.
So, people are working with their local hospitals. And in fact, I have a question for you, but it might be nice, Deirdre, if you wouldn't mind kind of telling us, because Deirdre is not in healthcare, but she's worked intensely the last 2 years with her local hospital system in Nevada, I think. Do you mind
No,
just kind of telling us where you got to?
yeah. So I'm not in Nevada. I'm near Nevada. I'm in the Lake Tahoe Basin, Truckee, California, and we have a publicly chartered healthcare district that runs the major hospital system in our area. And so we are able, they have board meetings. The board meetings are open to the public, and we're able to make 3-minute public comments per person. So after failing to get any attention or being able to build any bridges behind the scenes to administrators in the hospital system or the board, we started over a year and a half ago making public comments. And we had a rotating group of people who did it. We brought them information about what other hospital systems were doing. We brought them information about many of the same things that you've spoken about. And eventually, we convinced them, really at the point where we thought we should give up. They decided to do a greenhouse gas inventory, which was the first step toward creating a climate action plan. And they hired a well-known, well-respected firm in California to do that. So we were very pleased about that. We also had tried for about a year and a half to get them to send staff members to the Practice Green Health Green Med conference. And this year, because it was held in Salt Lake City, which is not that far from where we are, they sent 2 people, their facilities director and their government relations person, to that conference, who came back actually having found some religion and and suggesting a way forward. The hospital has had some other problems that have kind of gotten in the way of this, but we think will probably eventually help us. They're replacing our CEO. The CEO was believe it or not, nobody believes this when I tell them this, but the CEO is a climate denier.
Oh,
So anytime we tried to do anything, he was kind of behind the scenes,
yeah. Yeah.
avoiding doing it. So we've made that progress, and we're going to continue to make public comments and continue to push. Our next suggestion is that they form a committee to work on sustainability and climate action, and that committee contain members of the public, because we actually have in this community quite a few experts who could be of help to the hospital system. One of the things we're hearing, and I'd be interested if anybody has heard this, which has us a little worried, is that there's now some pushback that, and we also got them, by the way, to join a regional climate transformation alliance, which is a coalition of nonprofits and service districts and businesses and individuals all working on reducing greenhouse gas emissions in our region. That just happened last week. So that's another thing we worked about a year and a half on. So, but we're now hearing, well, you don't understand how challenging this is for us because we're such a highly regulated industry. Now, our answer to that is, well, there are other members of your highly regulated industry who are doing this. So why don't we join some organizations that will help you to learn how they're doing this and how they're overcoming these problems? So that's probably going to be our next push, along with a climate action plan.
That's wonderful. And Kathleen and I are working on a 2-pager with information for like those that are pre-contemplative, to kind of give them some of that foundational knowledge. And we're trying. Neither she nor I are like super savvy with Canva, but we're trying to make it so that you can like switch out colors, so you could put in like your hospital colors and things like that. So there's going to be that, and then we'll have another 1-pager on what the ask should be. So like having a chief sustainability officer, a paid position that's integrated within the organizational structure, because you could have a green team with no power and no ability to do anything. But if you have representation from nursing, from environmental services, then that builds a little bit more efficacy. And to your point about others are doing it, yes, that the examples, I think that the peer pressure is really helpful. So like finding like the next door neighbors that are doing it is super helpful. It sounds like you're already doing that. One of the other agencies that you might find helpful is the Healthcare Anchor Network, because that's not just on sustainability, that's more the health system as the anchor in their community. For many of us, that's the case. Like for Cooper, we are totally an anchor in the community. We're hiring people from the community. We're sourcing things locally. So it can be seen as an extension of that. And I forget how many hospitals belong to that, but there's a lot. So, and then when you join that, then you become part of these regional calls. And so to your point about the information sharing, that's an avenue too, then where people can discuss, what's working in your state, recognizing that there's different regulations. I even found, much to my chagrin, that some of the things that were cost effective in California are not cost effective in New Jersey. So like, for example, I wanted to get rid of our plastic gowns, like they drive me nuts. But there was all this cost efficacy studies out of, I think it was UC San Diego. I tried to do it here, and I found out that our labor costs were so high that it cost $1 to wash a gown once. And so that completely negated any kind of cost benefit from reusing the gown. So that type of work also has to be done. It has to be transposable. Yeah,
Thank
makes it
you.
complicated.
I had not heard of the Healthcare Anchor Network, so I'll look it
Yeah,
up. Yeah.
yeah. Their CEO is also very approachable. He'll reach right out and talk to your CEO.
Any other people with questions or with comments on, what's happened in your area?
I can drop my email in the chat too, if you think of any kind of comments for me later on or questions. I'm happy to try to help or at least direct you to the right source.
I
I would
have,
like to get updated on the Joint Commission, if possible. I
Yeah,
understand they were going to be fairly heavy-handed initially, and somehow now that there's just some sort of voluntary certification process.
yeah, yeah. So Jonathan Perlin really wanted to have this these mandatory standards, but because they got so much pushback from the medium-sized hospitals, they backed down and went to just a voluntary sustainability certificate. So that's where it stands right now. They still very much want to move towards mandatory reporting. But they also have to sustain a business, albeit a nonprofit. So the concern is that these two smaller accrediting agencies could, if you're, I don't know, St. Luke's, and you say, I don't want to be sustainable. Well, I just won't sign up with the Joint Commission. I'll go with DNV and I'll have them accredit my hospital on behalf of CMS. So I can still do, everything that I want to do. I can still do my quality reporting, my infection control, but I just won't have to report sustainability. So the Joint Commission didn't want to lose that much of the market share. And so that's why things are the way they are right now. Our hope is Harvard has these CHA fellowships, these climate health organizing fellowships for small groups of people. And they're great. They walk you through how you do community organizing. And so two of the groups within our consortium's Climatesmart Healthcare Committee is going to be taking this on. One's going to handle trying to get DNV to have a sustainable certificate that's voluntary, and one for HFAP, so that at least all of the accrediting agencies all have the same voluntary certificate. And then, of course, we would hope to push from there. I think there's a question in the chat. Do hospital CEOs ever ask for a price on pollution? It seems it would cut through so much of the complexity. It would, except they can't even get their heads around how to start a greenhouse gas baseline report. So and the other thing is that the price on pollution, it's tricky really, because then it comes down to like, we really need to reform the whole healthcare system because the hospitals are reimbursed by care episodes. So it doesn't necessarily 100% behoove them to have a totally healthy populace that's not coming in and feeding the hospital with sick visits. If our entire health system moved to more preventative care, then yes, a price on pollution would absolutely make sense. But right now we're prioritizing secondary and tertiary care, which, admittedly, as a hospitalist, that's what I do. So I understand the irony here. But really we need to move to more primary prevention. And then a price on pollution would really make sense.
I would add in, just because Cynthia and others, we've had this conversation a lot within CCL and out, is just hospitals, like so many, like a business in the community, they don't want to, annoy, certain segments of the population. So
Yeah.
they're very reticent. Hospitals just don't, unless it's directly related to hospital care. Like they, hospitals and of course the MMA and different people have lobbyists in your state legislature, but they're not going to stick their neck out and
No.
annoy all the fossil fuel industry. They're just not
Right.
going to do it. I mean, when you talk, when you talk to the people who are, the hospital systems that are enormously on board with this, and really, even if you look at Healthcare Without Harm, Gary, whatever his name is extremely in favor of a carbon price, but he doesn't even talk about that in the circles there.
Interesting.
Rita?
And Ritu?
Hi, it's Ritu. Um, yeah, thank you. This was so comprehensive. Two comments. I would agree with Laurie. Like I've talked to, and you obviously know all this, is talk to health plans and health plans who are in certain states. They are reticent to even say climate change. My and this is again, everybody might know this, especially since you're from the medical society, is the Climate Health Now, which is a California association, also has a fellowship. And it seems like I'm volunteering for them. It seems like at grassroots level, like providers are coming
Right.
up with such great solutions, which could not only save the health system money, but also help with the greenhouse gases. So I feel there's a double bottom line, but I get it. It's stuck in like some
Yeah.
old story out there.
Yeah, yeah, and I think both. So the healthcare without harm system is more of a policy that like they were really pushing hard for people to sign on to the HHS pledge. So it's kind of like the more top down approach. The Medical Society Consortium for Climate and Health is more of a grassroots up approach. So I think both are very complementary. You need both of them, really, because you don't always know what's going to take hold, what's going to work. Well, one of the other things that I was thinking as you were talking that I didn't mention, another federal policy lever would also be building codes, because when you're talking about health systems, for example, like in the Northeast, we're so condensed, and so you'll have health systems that are cross state, and I mean this happens all over the U.S. But if a hospital did want to become sustainable, they would have to have completely different plans in New Jersey versus PA. And so if there was uniformity to the building codes, like there was an upgrade to the building codes, for example, only 9 states took part in it. New Jersey was one of them. And so when we're building a new building, it's going to have to abide by those codes. But we wouldn't have necessarily done that if if the state didn't adopt those building codes. So there's even opportunity there, even in the things, boring things like building codes that you wouldn't think about.
Just a couple of minutes left. Anybody else with?
Yeah, I I have a question or something to share. One of the other things that we tried this year, and that's again because it's a public healthcare district, so board meetings are open and public comment is solicited both on non-agendized items at the beginning of a board meeting and on any item that is agendized on the board's agenda, the public can make a comment. So we noticed that the board was going to be looking at, they have an executive incentive compensation committee, and they were going to be looking at CEO incentive compensation standards for the next year. So we asked, they didn't do this, but we asked that they include progress on sustainability and climate change and climate action as one of the standards that the CEO incentive compensation would be evaluated on. And it seems to me that, if you want to motivate a CEO or if the CEO wants to get the message about what the board wants them to do, you look at the incentive compensation standards. And in our case, they were very limited, largely, concerned with financial performance of the healthcare system. So we're going to continue on that one because we think that, first of all, we have the opportunity to make comments, but we also think that that's a way to motivate the entire system to be more concerned about climate action.
That's a great
Thanks,
idea.
Deirdre. But since we have just 1 minute left, just since Lisa mentioned it, Jerry Lawson, who's with the Energy Star program with EPA and works in small businesses and faith communities, is going to be our speaker next month and talk about how Energy Star could help us in hospitals or clinics. So let's all thank Lisa very much for her time, and hope they got all your kids to bed before the end of the talk.
We'll see. We'll see how many of them are wandering around.
All right. Thanks so much for everything that you do, Lisa.
Thanks, Lisa.
Thank you. Thank you. You've all been lovely. Thank you.
Thanks so much.
Bye-bye.
Good night, guys.